Thank you, Dr. Singh, and I appreciate the opportunity to present on exercise in the heart for the Midwest Women in Cardiology Symposium. Thank you. I have no disclosures. The objectives for this presentation are to answer the questions: why exercise for heart and vascular health? What are current recommendations for exercise? How are we doing before and during the era of COVID-19? And discuss briefly on the cardiovascular impact for SARS coronavirus 2 or COVID-19. So we know that regular physical activity or any bodily movement that results in energy expenditure beyond resting levels reduces the risk of dying prematurely, from dying from heart disease, the risk for developing diabetes, hypertension, colon cancer, breast cancer, improves sleep, reduces feelings of depression and anxiety, helps control weight, helps build and maintain healthy bones, muscles, joints, helps older adults become stronger and better able to move about without falling, and promotes psychological well-being, in addition to other immune-based effects that we'll touch on. Cardioprotective mechanisms of physical activity include psychologic, antiarrhythmic, antithrombotic, antiatherosclerotic, and here I want to highlight that you can raise HDL and lower LDL, as well as improve your LDL particle profile with physical activity and exercise, and then hemodynamic effects as well have been demonstrated. In participants in the Women's Health Initiative, at women who were age 65 pre-breast cancer diagnosis were followed, and women who had higher MET hours per week, so greater than 18 here, were a higher proportion surviving without cardiovascular event over the subsequent 16 years since breast cancer diagnosis. And this correlated with the number of MET hours per week of physical exercise and activity, so a protective effect. We know that with atrial fibrillation, exercise per week, 120 to 200 minutes per week over the short term, has been shown to reduce AFib burden, reduce symptoms related to AFib. And in the long term, people who are active over greater than 4 years had increased AFib freedom and reduced symptom severity. These potential mechanisms relate to reversed atrial remodeling, weight loss, improved blood pressure control, glycemic control, reduced inflammation, and improved autonomic tone. So all known effects of physical exercise and activity. In this study, training and completion of a first-time marathon, there was reversal of age-related aortic stiffening and reduced central blood pressure or aortic blood pressure. So people who had never done a marathon trained for 6 months, and there was a change in the biologic aortic age as a result of this exercise training, and also showed reduced blood pressure, central aortic pressure. So that's a direct effect of running. So if you're not a runner, what options do you have for moderate and vigorous intensity physical activities? So moderate intensity include brisk walking, bicycling, water aerobics, tennis, doing doubles, ballroom dancing, or general gardening. More vigorous just is more intense of those exercises. So uphill walking, race walking, bicycling at a faster pace, running or jogging, tennis, playing singles, aerobic dancing, heavy gardening, digging, or hoeing. So I often ask patients, what are you doing? Because they might not think of gardening as exercise. But the physical activity guidelines for Americans 2008 show 150 minutes, 2.5 hours a week of moderate intensity, 75 minutes, an hour and 15 minutes a week of vigorous intensity aerobic physical activity, or an equivalent. This does not have to be a perfect regimen, so any mix, but working to stay physically active has benefit. Where were we? So the American Heart Association statistics published earlier in 2020, if you focus on the right side of this chart with the column women and looking at ideal physical activity is the green bar. And from 2006 to 2020, there is improvement, so projected and target, as published earlier this year. And then with physical inactivity, also published earlier this year, there is a decline, a steady decline of self-reported physical inactivity for women. So we are getting people more active and moving. But then we had SARS-CoV-2 and this novel coronavirus, and we now know terms like COVID curves and the quarantine 15, and also knowing that this virus can affect the heart. what were people doing activity-wise. So this chart from the Fitbit blog reflects the decline in Fitbit steps recorded as of March when the pandemic was declared and people were having different levels of activity, but here with Fitbit decreased. So looking at the immune effects from physical exercise, so moderate regular exercise, and I would call this kind of the glass half full aspect, where immune surveillance, vigilance, and competence are all increased for people who have moderate regular exercise. There's an improved response to vaccination and then reduced markers of low-grade inflammation if you participate in moderate regular exercise. The glass half empty or downside of exhaustive or prolonged exercise is that it has been implicated in negative effects on the immune system. So transient susceptibility to infection in the setting of exhaustive or prolonged exercise efforts. So that is not as beneficial at this time. And looking at exercise in the SARS or CoV-2 era. So this is just from a question and answer session, but I thought the graphic was helpful looking at cardiac involvement with COVID-19 infection related to the great inflammatory response with cardiogenic shock, stress cardiomyopathy, direct myocardial injury, effects from hypoxemia, fever, or viral effects, and then effects for arrhythmia. Definitely can have cardiac involvement. The known unknowns here include, do we have cardiac effects in the setting of asymptomatic infection? That remains to be clarified. Is there a defined timing of cardiac involvement at the time of infection or after febrile illness? Is it defined by elevated troponin? We know that athletic training can have effects on our electrocardiogram and cardiac structure, and also athletic training and acute exercise can cause elevation in high sensitivity troponin, but how that relates with COVID remains to be determined. We have guidelines for myocarditis. So the established guideline I've given to you here is fairly conservative. So really, before returning to competitive sports, taking 3 to 6 months of not intense training and making sure that you have cardiac recovery. So this is all level of evidence C, expert opinion, but at this point, this is how we would approach someone who had a myocarditis illness. Where are we with cardiac rehab and supervised exercise therapy for PAD programs? These are very important clinical programs for our patients, and they have been affected by external factors such as government restriction and gym closures. Program operations have been modified. A lot of telemedicine has been helpful for patients in this pandemic setting. And then we've had to look at patient selection and risk stratification for COVID-19, as well as infection prevention and control for both associates and patients wanting to get back to their cardiac rehab and supervised exercise therapy for PAD programs. The AACVPR has a good outline for how to return with care and safely open your program. So finally, just for recommending to patients, I have had, recommendation for patients to consider wearing a mask if you're exercising where you do not have good distance with other people. If you need to back off on the intensity of your exercise, that's fine. And I always include in my conversation that I would not advise exercising with a febrile illness. So in conclusion, regular physical activity and exercise is an excellent way to multitask for heart health. The current recommendations for exercise can be adapted to the COVID-19 era, whether that's home-based or socially distanced physical activity. In general, I would still encourage you to avoid sitting and rest if you're unwell or febrile. Thank you.